I was in the right place, right time at HHS, at the Department of Health and Human Services, where mental illness, substance use, behavioral health diagnoses become something you heal from rather than what identifies you, and where you get to the point where it's no longer moral failure. It's also controversial because it's a potential disruptor to the existing behavioral health incumbency. Let me just give my 3 rules for leadership I try to follow: transparency, integrity, and competence.
Good morning and good afternoon, everyone. Thanks for being with us today. I'm Leah Mix, CEO of Delphi. It is a true honor to welcome Dr. Leith States to our Insight Session today. Dr. States is a physician executive and veteran whose career has spanned the battlefield and the boardroom and the highest levels of public health leadership. He's a board-certified preventive medicine physician and formerly served as Acting Assistant Secretary of Health and Chief Medical Officer at the U.S. Department of Health and Human Services. In those roles, Dr. States helped shape national public health strategy across a wide portfolio, which included behavioral health and substance use policy, disease prevention, health equity, and cross-agency coordination, working with federal agency partners to translate emerging evidence into real-world policy and operational guidance. His work often involved stewarding complex, high-stakes issues at the intersection of science, ethics, and public trust, including the responsible evaluation of psychedelic therapies. And I just want to make a personal note here that in my work with the federal government, I had just enough proximity to Dr. States to observe the way that he operated and the serious issues that he was dealing with on a daily basis, affecting millions of Americans' lives. And he always was going about it with a cool head and a warm heart. And for that, I have so much gratitude for his service in so many ways to this country and to all of us. Dr. States earned his medical degree from the University of California, San Diego, and his master's of public health from Loma Linda University, and is widely respected for his ability to bridge science, service, and system-level impact. We are especially grateful for his thoughtful engagement in the involving conversation around psychedelic therapies, and for his advisory role with the Ibogaine Healthcare Policy Institute here at Delphi. Dr. States, thanks so much for joining us today.
Thank you, Leah. And thank you, Loris, for the support getting us all together. It is an absolute pleasure to be sitting with you. Thank you for the invitation.
Oh, our pleasure. And I know that our audience today is going to be really interested in this conversation and your background and how you see psychedelics and Ibogaine. You have a very unique line of sight on this. First, starting a little bit with your personal background, you've moved through military service and federal public health leadership and now emerging therapeutic policy and much more. That's just a thumbnail. So looking back, do you see for yourself a through line that has connected these chapters of your life?
So I struggled with this question, Leah, for a couple reasons. One, there's a certain serendipitous quality to where I am now compared to where I started, where it's almost, and I'm not calling myself Forrest Gump, but it's that Forrest Gump moment where you just show up and things continue to happen, where you're wrapped up in history or you're taken away in a wonderful pursuit on an initiative that you were just fortunate to show up that day to work. The other piece for me is that this became an oddly mirror-like space for me to operate in, from the standpoint of very personal experience and tied to what I now perceive as the absolute transformative quality and nature of these medicines. So it's a complex piece, but in terms of a single through line, I think it's something that maybe 2 words: patience and curiosity. That capacity to continue to be open-minded, to be adaptive, to be critical across systems, but not be beholden to them, is maybe the most important through line that brought me to a space of being part of this work at this stage. So I know hopefully folks can align and resonate with that a bit. especially in this space. But happy to drill down into that further.
Yeah, that's great. There's something about being able to understand and see the systems and how they work, but also to be able to float above them and not to get bogged down in how things have to be, but to be willing to think outside of the box where possible. And I definitely have seen you in that capacity. It makes me wonder about your role as a doctor on the front lines and then how you bring that into your thinking about public health policy.
So that's maybe I can relate in example from my early medical career. And it really is two things from my early career. One that has informed maybe my view of public health leadership and leadership in general and what it means to be a public servant. And then looking at what it means to be a doctor in that space, interfacing with population and individuals. For folks that don't know, my background was active duty in the Navy as a medical corps officer. And I spent a fair bit of my career serving with the Marines. For those that don't know, the Marines are a knuckle-dragging bunch that really value physical fitness, strong leadership, and the capacity to command fire superiority on the battlefield. One of the first and the most important things I learned as a leader was from Marines while deployed. This was a training mission where we were deployed to India. And it was innocuous enough. We were getting ready to get chow, and we had the Indian Army contingent that we were training with get up for chow first. And what I noticed was the most senior officers were in the front of the line, followed by the next level of officer to the junior officers, followed by senior enlisted, all the way down to the most junior enlisted, which was afforded the opportunity to eat dead last. When I saw the Marines get up, what I saw was that most junior, that youngest Marine being at the front of the line, followed by the NCOs, followed by the staff NCOs, followed by the junior officers, and ultimately by the most senior officer in that element. For us, it was a captain in 03. And I became aware that one of the ethos mantra refrains for the Marine Corps is officers eat last, meaning you take care of your people first. It is incumbent upon leaders to always be focused on the people, on the mission, and not the self. So from that standpoint, as a leader or participant in public health and public service, it's always, how can I be accountable to, a good steward of, and responsive to the people I'm serving? So that's generally the people that have the least, are the most vulnerable, and don't have a voice. The second piece in terms of how I came around to my perspective of a physician in public health. I was in the middle of a deployment to Afghanistan. And this isn't going to be, I don't go down the war stories, but this is just an aha moment I had when we were getting ready to redeploy, when we were getting ready to go back home. And I was doing our redeployment briefs. These are the things you put in place to say, don't do stupid things when you don't feel we get home. Don't drink, don't drive, don't use drugs, don't beat up people, and be good boys and girls when we get back. And it became abundantly clear to me that the greatest good I was going to have as a physician was in keeping my population healthy, to address the boo-boos before they became boo-boos. So that's the ounce of prevention, pound of cure perspective. And it fully aligned with what preventive medicine and public health is. And I had no idea about this thing until I was sitting in the middle of that desert. But when it comes down to it, that's what got me to the point of a widened perspective of a doctor outside of the confines of a clinic. That my greatest good was in doing the greatest good for the greatest number as early on as possible. So those are two of the driving things that have kept me going.
Wow, that's incredible. And so being able to take those personal, professional, real world experiences and then zoom that out and extrapolate that to what does that mean when we apply that to large populations and a public health lens and leadership in public health. We take care of our people and we keep them healthy. And you've certainly made good on those awarenesses and those epiphanies that those experiences showed to you.
Incremental wins, slow process. We get some watershed moments, but by and large, it's just incremental, slow moves.
That sense of realism, I think, is part of your success. That is characteristic of your leadership, and also humility. So we could probably go all day with me complimenting and praising you and you finding ways to backpedal it a little bit, which I think is just another indication of the character that you bring to this work. Could we shift to talking a little bit about psychedelics? It's really an important topic for us. And this has been, in your time as a doctor and public service, the perspective on psychedelics has shifted radically, and for me as well. I wonder about when psychedelics first started coming into your professional field of view, and what made you take them seriously as a public health topic rather than dismissing them as fringe or seeing them more as a cure versus something that could harm.
So this is a Forrest Gump example, okay? I was in the right place, right time at HHS, at Department of Health and Human Services. Congress was receiving a number of inquiries from the outside world about psychedelic-assisted therapies. The previous administration was starting to receive a number of inquiries and starting to see things in tea leaves in media and press and things like that. So the division I was in at HHS, we were advised, guided, volunteered for the task of coordinating and thinking through psychedelic assisted therapies in an intentional way, not just within HHS, but across the interagency, across the rest of the federal government. As most things go when you're call it a scut monkey or a cog in the wheel, I was volunteered to take that on. Dr. States, you go ahead and lead that effort. So prior to that, I was absolutely naive. I did not understand the rapid progress, the emerging evidence, the way things were shaking across that landscape and potential disruption into psychiatry, mental health, behavioral health, and all manner of just how we treat these substances and interact with them as a society. So my learning curve was very steep, and that was back in 2022, I believe. So that's how I got involved from the outset. And that's how I started to cut my teeth on the state of the evidence, whether that was clinical trial, harm reduction, implementation science, the real world data that we're starting to see. And of course, since I was coordinating efforts, I started to hear perspectives from my interagency partners, but more importantly, I was starting to meet with the outside world and see what advocacy groups across the entire spectrum. This is from pharma to tribal perspectives around indigenous rights, First Peoples considerations, and what that really meant for our relationship for a society that just was not ready and still largely is not prepared for what these medicines will be like on the other side once they do have a more expansive footprint for use. So that's the protracted answer to how I got engaged.
Yes, and so it sounds with this assignment that you then were exposing yourself to the information that was available and that had an effect on how you viewed psychedelics.
It's that wonderful piece of collecting data points and then developing relationships. As a public servant, we're charged, one, with having an understanding of topic areas of importance that are going to have downstream influence on populations. But the other piece is that some of the best sources of information come from proximity, and that proximity to other people and their experience. So that is where I started to cut my teeth even more, was to start to understand. And this is where the anecdotes are important, where you see the trends in community levels that start with a single voice, a single family, a single experience, and it magnifies and trickles out, and you start to identify the resonant themes of the kind of the consistent through lines. So that those are the things that started to not weigh on me, but inform my understanding.
That really resonates with me. Even though I was maybe more on a self-assignment, I also started with the research and really reading that first before I got involved whatsoever. And then through the relationships and meeting people and really starting to deeply understand from lived experience of other people, as well as also the researchers and so forth, that sat with me too and brought me deeper into the conversation. And then it became a conversation between me and psychedelics. And I'm so glad to have met you in that conversation.
Yeah.
From your understanding that you've gained so far, how do you think psychedelics are different, if at all, from other emerging therapies?
Boy, are they different. It's an endless stream of ways they are different. Let's see, the best way to cut this. If we look at the historic understanding of mental health, behavioral health care through the lens of the DSM, through the lens of a subjective, imprecise approach to address what's not explained by other things. I think that's been, granted, I'm not a psychiatrist, but I know my psychiatrist friends do feel at times that they're the forgotten or left out specialty because there is that lack of precision. But I think in that lack of precision, sometimes you become beholden to dogmatism and you hold on to the things you think you're controlling because you don't want to go into the chasm of uncertainty as a provider. At least that's been my experience as a doc. We don't like to do those types of things. And the system of healthcare and medicine in general. So from that standpoint, psychedelic assisted therapies are entering into an established approach to behavioral health that is already broken, that's under-resourced, undermanned, not paid for well, and not understood well by payers, by health systems, and by the providers that really are charged with, in many instances, serving as the pseudo belly button or touch point for patients. So you get discoordinated care, you get ineffective or insufficient use of existing treatment modalities, you get dropout, or you get the folks that are just chronically on a given treatment modality because that's all that's available. And we become relegated to that idea of over-medicalization, diagnosis, having disorder run your life because there's no other way to frame it or characterize that archetype you now fit. I think psychedelics really do step into a place of disrupting that entirely. I don't think that they are a replacement for, I think they're an adjunct to the existing behavior treatment paradigm and armament that we have. So from that standpoint, the differences around preparation, around length of use, around expectations, around restoration, around wellness, around how patients view themselves and restore their capacity to have this autonomy and independence, where mental illness, substance use, behavioral health diagnoses become something you heal from rather than what identifies you, and where you get to the point where you're no longer, and I'm going to bring up specifically SUD and behavioral health, it's no longer moral failure. It's something that is able to be overcome and healed from. In saying that, there are so many devils in the details, and I don't think just because you get a drug approval or you put it in the water, it's going to make everything rosy. There's so much that needs to be teased out around adjunct provision of care, the sequencing, the timing, the type of integration, the type of provider training before you get to a point of what this actually means in practice. But that's all coming, and that's all very exciting. And that was very convoluted, but I hope that made
I
sense.
think that much of our audience today will be somewhat familiar with the things that you're referring to. And I think that is a very skillful overview of the promise and complexity around psychedelics as an emerging therapy. Some examples come to mind. Suboxone or Subutex is the current treatment for opiate use disorder. And someone is on that indefinitely, or methadone. And so they haven't actually overcome that disorder. They're just addicted to something else to prevent a more harmful addiction. And so the opportunity, especially when we start to look at treatments like Ibogaine, for, as you say, for the disease to no longer be what their life is oriented around, and for them possibly just not to carry that diagnosis anymore. That is extraordinary when we look at a myriad of conditions that hasn't been true for in the past, especially in psychiatry, especially in behavioral health. I've thought a little bit about the correlation between this and cancer treatment. And there was a time when cancer was almost always a fatal diagnosis. And then a tremendous amount of research and funding was put in to cancer research. And now people get diagnosed and they go on to recover and live from cancer all the time. And that seems like where we're at with psychedelics and especially mental health and behavioral health indications.
I think that's absolutely right. And it's so important to look at the past in terms of those use cases and examples that give us not just potentially a bit of a roadmap, but also the hope to stay in and press forward with evidence development, to understand that the existing processes and structures and the institutions are working. And here's the example being that transition of oncology to a precision-based specialty. You have immune modulators now. Melanoma was a death sentence. Now you actually have therapies that can affect cure, and you have 5-year survival rates going through the roof. And this is one of those watershed moments where it took time and resources and money and continued engagement and coordination. But yes, we realized a tremendous series of wins in that space. The area of psychedelic assisted therapy certainly is ripe in that. Example being, there's been pushback and consternation around the NDA pathway with the approved drug pathway at FDA. But there are maturation and movement flexibilities within that structure at the FDA to actually adapt to what are new medicines, these new constructs, and find ways to get these randomized trials through. So you can go through discovery 1, 2, 3, and we can actually get to a point of hopeful REMS that, like Subutex and others, won't be hopefully too restrictive, but restrictive enough to retain public health and public good while we're finding our way with coverage and all the items of implementation and actually serving the folks that need it, as opposed to just a cash pay landscape that's really not going to affect the good we're hoping.
So the system is adapting, but it's a process.
Absolutely.
Yeah.
A slow
Yeah.
process at that.
Yeah, so it goes back to what you're saying about the incremental steps and really keeping our eye on that. Are we making small but meaningful and foundational steps forward? And I think that you've just pointed to several of those. So that's really hopeful. I'd love to shift and talk a little bit about Ibogaine specifically. This medicine occupies a somewhat different space than most other psychedelics. I'm wondering, from your perspective, what makes Ibogaine unique from a public health and safety standpoint?
Ibogaine it's powerful medicine. It really, truly is something that has immense power, and I'm so glad that evidence is being built to actually demonstrate and convey in a qualitative fashion what that power is. A transformative agent that works across SUD, AUD, PTSD, TBI, neurocognitive issues, neuroimmune. There's a variety of emerging benefits that certainly are still early. You have quite a few case studies, use cases, cohorts here and there where you need to have actual prospective look to understand cause and effect, and that will come, but there's so much promise. Because of the medical stringent nature of it, it requires to be in a medical home, whether that's the potential for cardiotoxicity or the sheer way that the time sitting with the medicine goes, and the tele support and the provider support and just the significance of the journey itself. It lends itself to the confines of medical home and not necessarily going outside of those confines. So I think that it's something that is ready-made. And I say that with a qualifier because we've had the experience in the 70s, 80s with Howard Lotsoff and others around trying to push it through FDA previously and hitting a stone wall. So from that standpoint, it's also controversial because it's a potential disruptor to the existing behavioral health incumbency, as we talked about. Methadone, Subutex, Suboxone, the liquid handcuffs that keep you in chain for your life. This is a restoration. This is actual healing. This is something that takes you from disorder to I'm me, and I'm not identifying with that archetype anymore.
So part of the challenge is that the system as it exists right now, it aligns certain incentives in certain ways. And when you add something that actually treats people, that's a disruption for some of those incentives, some stakeholders in the existing system, which doesn't mean that we don't move forward. It means that it needs to be done in a thoughtful manner. And I think you would agree with me that it doesn't mean that we take the other options off of the table, because Ibogaine will not be appropriate for everyone. So it's just more options and more tools for healing.
I couldn't have said that any better myself, Leah. the incumbents, the folks that are going to be disrupted, do need to see themselves in the future of this landscape. So I will always come back to these are an augment to, not a replacement for the existing armament of what we can use to help people get better and be restored. And to your point, Ibogaine isn't available for everybody. Everybody won't be appropriate for it, but there are a significant and emerging contingent that are, it's going to be very powerful medicine.
And part of my hope is the cost savings that's incurred when people are no longer dependent on the system for ongoing disease management actually can be used to help those folks who aren't appropriate for Ibogaine to have greater amounts of care to hopefully be able to heal and live their best possible life with the supports that they need. Those are my rosy glasses.
One of the more exciting elements for me is, and this isn't one of those data points for evidence of shifts within federal government, and then I think just societally in general, is the ARPA-H evident program, where we're driving towards attempting to create this setting for a migration of behavioral health, mental health to precision, which would allow you to understand, hopefully in a greater degree. We have a series of biomarkers, a series of other types of modalities, whether that's imaging, evoked potentials from EEG, whatever the case may be, even getting AI tools based on talk therapy and what looks like it's going to be best for certain patients, to understand what adjuncts are appropriate to get that certain patient to health, specifically, a la the oncology model, where you're not going to get like a Gleevec silver bullet, take care of your CML for your MDD or PTS or whatever the case may be, but you potentially could get the right suite of options in the right sequence to actually affect the best chances of durability and recovery and wellness. That's very exciting for me. And that's been something that I know a lot of folks probably on this call have been quite excited about. The other thing that's quite exciting for this year, folks saw earlier this week, the DEA put out a rule on their quotas for a couple substances for fiscal year 26, specifically psilocybin and 5-MeO, increasing the quota amount to increase the throughput for research. And I would like to think that at some point, Ibogaine could find itself on that list of increasing the quota as we get more studies coming out, going through discovery in phase 1, specifically thinking of Texas is probably one of the first places that's going to put out some studies.
Oh, wonderful. Thank you for highlighting this response from the government. I think that's really what we need to hear. And when it comes to Ibogaine too, there is a difference in abuse potential from other psychedelics. So I too am very hopeful that the government is actually going to see Ibogaine a little bit differently. It's just not one that anybody's going to be using for fun, most likely.
So Colorado has their emerging model around decrim for Ibogaine. And it's so interesting to me to think about the contrast between Ibogaine and cannabis, because cannabis has been legalized across states for 20 plus years. Relatively high abuse potential. There was no currently accepted medical use. And then in the last 2 years, we've had an updated 8-factor analysis, and we hope would be a reschedule. You could say that Ibogaine has established a very high level of currently accepted medical use. And I think that's legitimate, where as states, and this is where I think there might be some opportunity, but concern as well. You could have states going through a reschedule process where either ballot or legislation to get to the point of bringing Ibogaine online before maybe clinical trial studies are completed. So I think there's always that risk of dissonance. And I bring that up as one of those eternal problems of the federal government interacting with the state and other entities. It is a risk. And for folks that are in public health, we have those examples of opioids or kratom as examples of how discordance between the federal and state government can actually lead to some problems. So I really exciting space. Ibogaine is such an opportune moment, and I couldn't be more excited to be participating in setting forward an intentional agenda that allows for evidence, policy, followed by public health, protection, and safety to be built in.
We're so glad for that. And you're advising, to that point, you're advising the Ibogaine Healthcare Policy Institute. And the field is still very early. Was there something that convinced you about giving your time and energy to this specific initiative?
So this specific initiative resonates with everything that gets me excited about public service. It's looking at the gaps right now in contrast to, or in relation to, the desired future state we endeavor to see. So it doesn't assume that somebody else is going to do it. It actually looks for what we need to do now to get where we need to be then, which is really important for me. And it allows me to just pour yourself out freely when you know that what you're doing is going to have impact. Sometimes you don't know if you'll get to the payout, but it's still worthwhile because of the process and the people. I also respect and value and enjoy the interactions with the folks that you brought in, Leah. I think that it's been highly encouraging, and it's really great to see an interdisciplinary group look at the same problem and stay focused on what the solutions are.
I feel the same. And there is a gap about what needs to be done that the research institutes and advocates and private companies just can't do those specific things. And so an entity of this nature is able to put pen to paper, rubber to the road, and actually move policy forward in a coordinated and mindful way. And we're so glad to have you with us so that we can affect that change. And it makes me wonder if we got this right and we looked back on it when it comes to Ibogaine, what would that look like? If you had a crystal ball, say 5, 10 years, 15 years from now, we really got it right. What does that look like, and what role do you think that IHPI has to play in that?
Now, I think some of this assumes that in the next year, we'll see probably two approved medicines that are psychedelic assisted therapies, probably psilocybin and MDMA, which will be first out of the gate to help provide for the agnostic infrastructure needed, whether that's workforce, payer considerations, CPT codes, effective REMS, bringing along the rest of the societal components and educating the public, educating providers, and then continuing to facilitate that transition from clinical trials research to implementation science to real world evidence, and then circle back again for the next in the line. So I would like to think that as we get through in the next few years, probably phase one, likely starting phase twos for Ibogaine, it is falling in, hopefully on an established infrastructure where we're starting to realize some of the benefits of the incorporation of these therapies in larger systems. So for me, the best example, and I'm a little bit biased because I am a veteran, but would be the VA system. You've got a closed loop, end to end, great data, mission focused providers, excellent capacity to get through wiggle room that other parts of bureaucracy don't. And then at the same time, you're able to see the sickest of the sick. You're not getting the unicorns of, oh, I just have PTSD. No, you're getting PTSD and SUD and AUD and heart disease. And I have uncontrolled diabetes and I've been a 2-pack-a-day smoker for 3 years, or I'm still dipping, those types of things, where you're getting the benefits of that promulgation out from the VA to the rest of the health system, public health kind of world. My hope is that's what Ibogaine is falling into. And in that time, you would have this maturation of specifically behavioral health, because I think that's where there might be some of the most pushback from the incumbents, where there is this understanding of the opportunity and space where this is being laid into a more, I'm not going to call it seamless, but a more complete and timely set of options that can be looped into patient care. I have not even thought about the decrim piece, the deprioritization, the potential for personal use that is going to continue to, I think, pop up and be problematic, not because folks should not have access, but because of the way that those short-term, short horizon, or small population-focused initiatives can sometimes add the wrong type of fuel to a fire. So from that standpoint, I do see quite a bit of risk. And then the other piece is the international consideration for me around the Bwiti people across Gabon, across India, from other perspectives, and the capacity to remain mindful that the medicine isn't necessarily what provides the cure. The medicine provides an opportunity in the set and setting And many times the folks that have done that best are the folks that did it first, and the folks that have curated and been mindful and stewarded and shepherded the medicine well and partnered with it over millennia, as it were. From that standpoint, I think it's complex, but my hope is that things are continuing to take incremental movements over the next 5 to 10.
Those who did the first human trials, really listening to them.
Yeah.
And as we know, the Americans for Ibogaine and a large, significant contingent of Americans are in Gabon right now, meeting with BT leaders and Gabonese leaders at an Ibogaine conference. So the conversation is happening. And I really appreciate what you were saying about the integration of psychedelics into the existing systems and how that could be done in a way that builds on itself over time as new medicines come online, the efficiencies that could be gained. If the system is made up of people, yes, there are rules and things of that nature, but rules can be changed. And every one of us, in some way, is part of the system. And so, just in closing here, I'm wondering if, for those in our audience who are leaders, decision makers, practitioners, what would be your advice about how to act responsibly and wisely? What principles do you think matter right now in relationship to how we're operating in bringing psychedelics and Ibogaine forward?
Well, I'm glad we're finishing on that. Let me just give my 3 rules for leadership I try to follow: transparency, integrity, and competence. And my rule under those 3 is I'm never the person that has all 3 of those things in the room. My best effort is to maybe at times have 2 of the 3, but I need to have people around me that can encompass all 3. So if I know I can walk with integrity, I may not be the best person to deliver the message transparently. So having the right people there, and I may not be the subject matter expert, so I might not be the most competent, but as long as I can keep that cadre or host of witnesses around me, I feel like I can move into new spaces that aren't comfortable for me with confidence and humility, as you were saying earlier.
Transparency, integrity, and competence. And doing that in a relational and collective way where we're someone in the room, whoever's in the room, we bring all 3 of those components to the table and are seeking those components out in our colleagues and benefiting from sharing our qualities and information and receiving and evolving ourselves, evolving our mindsets. You spoke a little bit earlier about dogma and the handcuffs that can be. So in what you're saying, I perceive this call to openness, call to open-mindedness as we move forward. So I appreciate that so much. I've been on my own path and continue to be on my own path with open-mindedness and hope that that the audience resonates with that. I'm sure that they do. This has been such a fascinating conversation. We had just so much to talk about and such a wonderful opportunity, Dr. States, to hear your wisdom and your perspectives on psychedelics and Ibogaine and your role in this work. So thank you so much for sharing with us today, for being with us today.
Absolutely. Thank you, everyone, for your attention, for your openness. Any questions that do come up or comments, thoughts, please feel free to share, and I'll certainly respond.
Wishing everyone a wonderful rest of your day and look forward to seeing you next month on a Delphi Insight Session.